Hello and welcome. This is the second Pacific Lipid Association webinar of our three-part series. This one on the topic of working with patients following very low carbohydrate and or ketogenic diets. My name is Kevin Maki and I'm the president-elect of the National Lipid Association. I'll be moderating this evening's webinar. At the end of the two presentations, there will be a 10-minute Q&A session. So please feel free to submit your questions via the chat feature in Zoom at any time. Also, a statement of credit will be available upon completing an online evaluation form. The deadline to claim credit is November 27th, 2021. Any questions related to obtaining credit should be sent to Kathy Thompson, and her email address is shown here at the bottom of the slide. We have two great speakers tonight, Dr. Carol Kirkpatrick, who will be our second speaker, and Dr. Daniel Soffer, who will be speaking first. And I'm going to let each of the speakers introduce themselves. So without further delay, I'm going to turn things over to Dr. Soffer, who will be discussing the role of very low carbohydrate and ketogenic diets in clinical care. Dr. Soffer?
Thank you, Kevin. I can call you Kevin, I hope.
Absolutely.
Thank you. Let me share my screen so I can bring up my slides. My name is Dan Soffer. I'm an internist and clinical lipid specialist at the University of Pennsylvania. These are my contacts. And these are my disclosures. Relevant to this discussion, I don't really have anything. So I'm going to be talking about, give you an overview and the genesis of the discussion that's taken place at the National Lipid Association regarding some of the key concepts in this dietary conundrum of a very low carbohydrate or ketogenic diet, and give you some of the background about how that conversation took place, and then what kind of evidence we talked about. And then we'll dive into some of the evidence. So I'm going to keep it at an overview level, relevant to my expertise. And then I know I'm going to turn this over to Dr. Kirkpatrick, and Carol will present some of the details, and we'll have a chance to really dive in and have some discussion about this. So, I think it almost goes without saying that we have a huge problem in our community, of course, with overweight and obesity and the associated medical conditions that go along with that. Of course, diabetes and cardiovascular disease is high on that list. The prevalence of overweight and obesity continues to rise around the country and in certain regions and around the world, of course, at alarming rates. And we know, of course, that weight loss improves cardiovascular outcomes and diabetes outcomes. And maybe it's ridiculous to say, but it's difficult to achieve that weight loss, right? That's something we all know, we've all experienced, and we've all talked to our patients who struggle with that concept. The very low carbohydrate and ketogenic diet is touted as an easier and efficient weight loss strategy with favorable metabolic outcomes. And that sort of is the genesis of how this has become started as a rolling pebble and has become a giant boulder of an issue. I can tell you that some of my exploration about this is really fairly recent and actually started with some NLA discussions at various meetings and hearing from some colleagues, I don't know, 5 or 10 years ago about this dietary trend of people going on the ketogenic diet. It's not a new thing, of course, but hearing about some of the popularity and rise in the community as becoming a more standard diet has really risen to a level of a popular diet. And of course, it started on the West Coast before it came to the East. And with that in mind, we started to have some clinical questions that came up in conversation amongst peers. And so some of the concerns that were being raised amongst peers in conversation was, does following a very low carbohydrate and ketogenic diet achieve optimal metabolic response? Is that really, does it do what we think it could do? Does it follow healthy dietary principles? The most popular low carb diet that preceded it, the Atkins diet, people were coming in talking about all the bacon they were eating and eggs and all kinds of other foods that, made everybody in our field cringe about the health approach there, despite whatever metabolic results were being achieved. Is it the best macronutrient balance? Like, is it really just about balancing the macronutrients? Some other major questions were, is it sustainable? Some people would come in and talk about how they could follow for a little bit, but then they just sort of lost the taste for it. And then if you do find a way where good outcomes are achieved, is it scalable? Can you really roll it out to large swaths of the community if we think that there's some value in it? So major issues raised in the clinic needed to be raised and approached in the scientific realm. And of course, that was ongoing in parallel. And this kind of led to a conversation, at least within our own organization, towards working on a paper to summarize some of the data that was available to us. For me, though, the straw that broke the camel's back for me in terms of wanting to push harder for us to have a working group on this was a clinical case. And I just present this briefly. I know Carol's going to mention this a little bit later, but this was a woman who came into my clinic, a 48-year-old non-smoker without any ASCVD, hypertension, or diabetes. She was a little overweight. I didn't write down her BMI here because I didn't want to get too distracted with details. Menopausal symptoms, really healthy person, no prescription medications. She took some fish oil and primrose oil for various reasons. And she had followed lots of different diets in the past for normal weight management. And when I met her, she was self-treating her menopausal symptoms with a ketogenic diet. You can see the impact that this was having on her cholesterol levels. Her total cholesterol had risen over 400. Her LDL cholesterol was in the high 300s. And her triglycerides and HDL cholesterol were not terribly remarkable. I don't want to get too bogged down by the abnormalities that are seen in that aspect of this. And you can see in comparison to where she was prior to following the ketogenic diet, she certainly had some lipid abnormalities before with very low HDL cholesterols at time and as mildly elevated cholesterol at time as well, but nothing in this kind of range. So clearly some abnormality existed before, but a major change existing that really changed the nature of her lipid disorder on this diet. And so when you look at it on average, you can see she went from a total cholesterol of 183 to 419, a dramatic change in her LDL cholesterol from 127 to 349 milligrams per deciliter. And so, raising the concern about whether this was the right kind of diet got me and others thinking in the diet world, sort of toys with whether we're looking at this approach the right way. And, it's very confusing in the clinic. People come in and they talk about how much carb or how much fat they should be eating. Then they also want to talk about, what about ultra processed foods, or what if I follow this particular diet, if I just stay with organics, so the quality of the food can matter. And then other people are coming in and talking about time restricted eating. I mean, there's so many different ways that you can break down the diet. And is there one specific approach that really can be summarized and give us the best information available? And so I'll try not to extend the color metaphor too much, but make sure that we're not necessarily comparing oranges to apples to lemons and bananas and blueberries and avocado. So, make sure that we're really comparing the right things. So the basic concept that lies behind obesity management has always been this sort of calories in, calories out. And, the party line has been, obviously, if you burn more calories than you take in, that you you'll lose weight, and that if you take in more calories than you burn, then you'll gain weight. And the consequence of gaining weight can be, abnormalities in all different types of systems. Listed there on the far right, you can see, everything from mood and body image changes to metabolic derangements and blood pressure and all kinds of consequences from being overweight. So we know it's something to pay attention to. The models follows that if we eat less and exercise more, that we'll go back to where we started, and everything will sort of normalize with that approach. But everyone knows that it creates a lot of consternation for our patients. People talk about having a change in their body weight set point, and it makes it very difficult to achieve a lower weight if all you're told is eat less and exercise more, if you're hungry all the time, and if you lose weight, you tend to gain that weight right back up. And so it's a very difficult process to achieve. The dietary guidelines for Americans are updated every 5 years, and presentation at the most recent NLA reminded me of some of the valuable lessons that we learned from the DJA, and those were reviewed very nicely by Carol at that time. And remember, the 4 pillars of the current guidelines are: 1, to follow a healthy dietary pattern at every stage in life, and 2, to customize and enjoy nutrient-dense food and beverage choices to reflect personal preferences, cultural traditions, and budgetary considerations. So basically eat high quality foods and make sure that the foods that make sense for you in your life. 3, to focus on meeting food group needs with nutrient dense foods and beverages and stay within calorie limits. So that's the eat less portion of it. And 4, limit foods and beverages higher in added sugars, saturated fats, and sodium, and limit alcoholic beverages. So they're talking about the quality and perhaps the origin of the food and how they're being created. So Americans, of course, follow these guidelines to exactly, or do they? So the USDA actually released some information from NHANES surveys showing, asking people whether or not they tend to follow, and asking the right questions to find out whether people actually do follow the guidelines. And maybe not surprising, older Americans tend to follow the guidelines better. That as many as 63% of Americans over the age of 60 are thought to be following the dietary guidelines of America pretty well. And much younger Americans, while their diet is controlled by their parents, tend to do it as well. But pre-adolescents and adolescents and adults tend not to follow the dietary guidelines nearly as well. So you can see there's sort of an age-related adherence to the dietary guidelines of America. So where are we doing well and where are we failing? If you look at the bars above the line and look at the bars below the line, you can see certain categories of success versus failure. So in green, you can see from the national surveys that we are failing miserably in terms of our total vegetables and fruit intake, that fewer than 30% of Americans are actually anywhere near the expected amount of fruits and vegetables. And that's the best category was other vegetables. I'm not even sure what other vegetables are, but when you look at the breakdown by which type of vegetables, you can see that almost all of those are clearly people are well below the recommended vegetable intake and even fruit intake. And then if you look at the total grains intake, that's where Americans are taking in way more grains than are recommended. But the amount of whole grains that they're taking in is far less. And so the types of grains that people are eating is basically refined grains. And finally, when you look at dairy and total protein foods, you can see it's sort of split. People are taking in far more meat, poultry, and eggs than are recommended. Seem to be split on nuts and soy products, but very low on seafood and dairy. And so you can see where some of the shortcomings are taking place and how that might affect things. How do we do in terms of added sugars, saturated fat, and sodium? You could probably guess this answer, right? We don't do great. We only about 60+% are taking in more added sugars than are recommended. Almost 3/4 of both men and women are taking in more saturated fat than's recommended, and almost every American is taking in far more sodium than is recommended. In terms of the sources for these things, when it comes to intake of sugars, you can see that sugar sweetened beverages, desserts, and sweets and snacks make up the biggest majority of foods that are causing us to take in more sugar than we're supposed to. In terms of saturated fats, sandwiches, and desserts and sweets and snacks. So desserts and sweets and snacks make it to top 2 on both those lists. and sandwiches and sweetened beverages on the others. And so I think you're basically talking about too much saturated fat, sugar, and salt from a sandwich, a soda, and a Snickers bar shown here, and that we should really be eating foods that look more like the picture on the left. And I know Carol's going to show you some other pictures that with some scrumptious looking healthy foods as well. And so if that's how we eat, despite guidelines and recommendations, and we know how hard it is to achieve these optimal outcomes, what if we had a different way of eating that had a different impact on the way we felt, and it wasn't quite such a stormy day when we tried to lose weight? Well, that's what's proposed with a very low carbohydrate and ketogenic diet. And the suggestion here is that if you change what you eat rather than how much you eat, by reducing your carbohydrate intake, that you can actually make some metabolic changes that take place that go beyond just calories in and calories out. And it's a different model of weight reduction and other metabolic changes than has been proposed in the past. But the concept is, with this type of dietary approach, you have reduced insulin to glucagon ratio, plus or whether or not you're in ketosis. There's enhanced lipolysis and fatty acid oxidation. And that maybe the most important aspect of it is that could these changes change the way we feel? Does it change the biochemistry so that you actually have less hunger and spontaneously reduce the intake? And so the consequence of that, we think, would be huge if that were the case, if it was easier to lose weight. As far as our MNLA working group paying attention to all these factors, there's way too many things on the list to assess response. But we did focus on diabetes, the lipid and atherosclerotic risks, and hypertension when we reviewed the literature that was available. And so you can see this is the working group and the paper we published in 2019 to address that. You can see Carol and Kevin featured prominently in the publication of this paper. Our group first decided that we better define this issue as well as possible, and using accepted parameters, it's important to sort of distinguish between the different types of diets. Our patients come in and confuse the language very frequently. It's something that I think we're all accustomed to. Somebody will come in and say that they're on a ketogenic diet or they're on keto, and when you really pare down and ask them and find out what they're on, it's really not exactly that. Well, the same thing tends to happen in clinical trials too. People are given particular parameters for following a diet, and sometimes even given specific foods, but may not follow it exactly. But you can see here that what we're focused on specifically was the very low carbohydrate and ketogenic diet, which is a diet that's not restricted in calories below 1,000 per day. You can be on a very low carbohydrate diet without being ketogenic, but a ketogenic diet by definition includes ketosis. A very low carbohydrate diet and ketogenic is going to be less than 10% of the calories from carbohydrate. And you can see fairly high fat content of 70 to 80%. And that's in comparison to the classic ketogenic diet that was introduced as a treatment for seizure disorders in children many I was going to say decades ago, but really generations ago. And you can see slightly different in terms of its super low carbohydrate intake and super high fat intake without any caloric restriction or variable caloric restriction. So the diet against which it should be compared is really that diet that's proposed by the dietary guidelines for Americans. And it's often referred to as the Mediterranean style diet. Mediterranean style diet has a lot of liberal definitions, but you can see that most of the things that I have listed here are not necessarily specified in a typical Mediterranean style diet, because it really just is an emphasis of the things pointed out in the dietary guidelines for Americans. So for example, calories can be ad lib, but what's emphasized is vegetable intake, lean meats, low or no fat dairy products, and that the oil should be vegetable based. We're told to avoid ultra processed foods, and trans fats, and especially high fructose corn syrup in a diet that follows the parameters of the Mediterranean style diet or the dietary guidelines of America for Americans. And it's not specified how much carbohydrate and how much fat you take in. So here's a diet that really focuses more on the quality, and comparing that to the very low carbohydrate ketogenic diet, which focuses more on the macronutrient content. And you can see some of the comparison and differences here. So again, we're back to the benefits and claims of a very low carbohydrate ketogenic diet, or that it reduces hunger, that it induces an easy weight loss. There's improved triglyceride levels, improved glycemic control. All of those have been claimed and also demonstrated, and I'll show you some of that data in a minute. There's the risks and concerns that we have are that you can lose some lean body mass on a ketogenic diet. I highlighted the increased LDL cholesterol because this is a lipid group, and now I'm a lipid specialist, and so that's something that of concern, and that's why we started with that case that we described. The concern about a transient keto fog or sustainability and unhealthy foods all are addressed as well. And a minor concern raised at the time was with the use of an SGLT2 inhibitor and inducing euglycemic ketosis. We thought it was a minor concern at the time. It turns out that this is a class of drug that's being much more widely prescribed than it was even then. So when in our review, we focused mostly on randomized controlled trials and meta-analyses of the same. We found that a lot of the data really came from these controlled captive feeding studies, which are not exactly real life, but can offer some interesting basic science information. There were plenty of academic and commercial studies that were randomized, and some case series studies to look at as well. There's a lot of small and very brief studies, and studies that look, when they sat down to create them, looked like they were focusing on one specific thing, but then there were a lot of variability on all of the other factors. So diet is one of those things that you can't just change one thing and expect that nothing else is going to change. And you see this a lot in diet studies where you think you're controlling one factor, but then other things are changing as well. The adherence issue is something that came up in a lot of different studies, showing us that even in a focus group like that, in a clinical trial, it's even hard to maintain strict adherence. And so some of the findings from these diets, when you look at network meta-analyses and you had a chance to compare low versus moderate versus very low carbohydrate or ketogenic diet, Mediterranean, and the whole gamut of diets, what was found is that with regards to hemoglobin A1C, that a low carbohydrate diet did outperform other diets, with Mediterranean style diet as second and moderate carbohydrate diet as third. So seems to have some impact on that, especially in short, more than long-term studies. In terms of fasting glucose, Mediterranean style diets had some advantage over some of the other diets. In terms of the lipid effects, moderate carbohydrate diets and vegetarian and vegan diets had the biggest impact on LDL cholesterol. In terms of HDL cholesterol, which may not be such an important finding, Mediterranean style diet outperformed the other diets. And that same effect was seen in lowering triglycerides, but low carbohydrate diet also outperforms the other diets. Overall, the Mediterranean diet, the Paleolithic, and low carbohydrate diet seem to have the best lipid effects. And so just to summarize the findings from our review of the available literature on glycemic control, low carbohydrate diets were not superior for fasting glucose or insulin levels. Low carbohydrate diets versus high carb, low fat diets for hemoglobin A1C, but less difference beyond a year. And low carbohydrate diets without ketosis reduced the use of diabetes medicine. So low carbohydrate dieting seemed to have a significant impact on glycemic control. In terms of the lipids, Mediterranean style diet improves triglyceride and HDL and A1C levels compared with low carb diets. And the blood pressure effects were inconsistent between diets. And so I don't think there's any one diet that outperforms other diets other than the DASH diet, which is a low sodium diet. So the key points from our review of the available literature at the time was that the Mediterranean style diet provides favorable cardiometabolic effects superior to those reported in very low carbohydrate and ketogenic diet. The very low carbohydrate and ketogenic diet and low carb diets may provide benefit in glycemic control and markers of insulin resistance. And those diets in a Mediterranean pattern may be the most favorable of them all. So combining this concept of a Mediterranean style diet with low carbohydrate makes a lot of sense. And that this is all consistent with the dietary guidelines for Americans. And so I don't think it really represents a dramatic change from their review. As a matter of fact, our colleagues who are probably the biggest proponents of a low carbohydrate diet have suggested in a recent paper that a Mediterranean style low carb diet with an emphasis on unsaturated fats provides a non-pharmacologic option to target both insulin resistant dyslipidemia and elevated LDL cholesterol. So sort of combining the processes makes sense. And so, I think we're left with our basic recommendations from the Mediterranean or DASH diet, and plant-based diets, plant-based foods, fish or seafood, lean meats and non-fat or low-fat dairy foods, plant-based oils, consume less high-fat red meat and processed meats, high-fat dairy foods, dietary cholesterol and sodium, and foods and beverages with added sugars. It remains our goal in recommending dietary pattern. And foods that are avoiding foods with a high glycemic load, I added there too. So I think we're gonna have a lot of chance to discuss this further, and I'm gonna turn this over now to Carol, who's going to continue the discussion, and then we'll have a chance to finish our conversation all together.
Thank you, Dr. Soffer, Dan. Very interesting information and definitely sets the stage for me to do my presentation next. Can everybody see my slides?
We can see them.
Okay, full slide. Okay, so I am actually going to have a little bit of information that Dr. Soffer already presented as well, but my role for our webinar tonight was really to focus more on the considerations and the practical application for when you have a patient who comes in to see you and really does want to try the very low carbohydrate and or ketogenic diets. And I think that Dan did a great job to point out that some people may feel like they're following a ketogenic diet when in fact it is a very low carbohydrate dietary pattern that's not actually putting them into ketosis. So I guess let me take a step back. I'm Carol Kirkpatrick. I just assume that everybody knows me. I am the Wellness Center Director at Idaho State University and also a clinical associate professor, and have been thrilled to be very involved in MNLA for several years now, including writing the paper with Dr. Soffer and Dr. Maki. And I have no financial disclosures. And so what I will discuss with you, again, a little bit of redundancy from what Dan discussed in terms of kind of the benefits and the optimal times we can talk with patients about following a very low carbohydrate dietary pattern. And then really what any person should be aware of is whatever dietary pattern that they're following, the quality is essential. And Dan touched on that as well. And then hopefully you will leave the webinar tonight with an idea of how to have a conversation with your patients on what foods they, regardless of what dietary pattern they choose to follow, what foods are associated with improved cardiometabolic health, which we want them to consume more of as often as possible. So just briefly, because Dan already discussed this with his slide set, and this is from our infographic that's available on our website. If you are interested in downloading that, it's a nice PDF. But the main thing I wanted to point out was the varying amount of carbohydrate, as Dan pointed out, and that for a person who is trying to especially achieve ketosis, their carbohydrate intake needs to be very low, so very restrictive, less than 20 to 50 grams per day, and that's very individual. Some patients can achieve ketosis at 50 grams a day, and some people have to go a little bit lower. So really educating people on that, and the fact that, with ketogenic diets, very low in carbohydrate, typically replaced with fat. If too much protein is consumed, a person is kicked out of ketosis, so it needs to be moderate in protein. That means replacing carbs with fat. Typically, it's not specified which type of fat. If a person's not working with a healthcare person to help guide them in healthier choices of fat, and they have to have the presence of measurable ketones, preferably through testing in the urine, which tends to be more accurate. So with our paper that Dan already presented for you and discussed really well in terms of a summary, what we had or found from our review of the evidence for our key recommendations was that if you look at the data, the meta-analyses that we had available for us, there really wasn't a macronutrient breakdown that was superior for weight loss, especially beyond 1 year. So really working with your patients to find out what's going to work best for them. We do believe and found from the evidence that for short-term weight loss, definitely low carbohydrate, very low carbohydrate keto diet typically does do better than the higher carb, low fat diets for short-term weight loss. So it may be reasonable for some people to start with a very low carbohydrate diet initially, but the evidence also, and as Dan mentioned, difficult to maintain a very low carbohydrate, especially restrictive enough to be achieving ketosis for many people. Definitely some people can do it and do fine and do well, but difficult for a lot of other people. So long-term, a moderate carbohydrate intake is reasonable for that long-term success, especially for maintaining weight and really trying to promote the consumption of foods that we know improve cardiometabolic outcomes and risk factors. So if we're looking for ideal patient candidates who may do well or benefit from following a very low carbohydrate or ketogenic diet, again, it's a patient who maybe needs that kickstart. They would do better if they felt like they were successful. And so definitely following a very low carbohydrate and or ketogenic diet would help somebody with that really quick initial weight loss. People who have moderately elevated triglyceride levels, so typically less than 500, they are going to definitely have some benefit from reducing carbohydrate intake. And that's not anything new. We know that a person who has elevated triglyceride levels, if you reduce their carbohydrate intake, their triglyceride levels improve. Does not have to be to the point of a ketogenic diet, but you will see that improvement. And as Dan mentioned, people with insulin resistance or type 2 diabetes needing some glycemic control definitely can be helpful for them. Same reasons for the triglyceride levels. And if they are motivated, especially if they want to do a ketogenic diet and achieve ketosis, they are motivated enough to maintain that severe carbohydrate restriction. The patients who we really don't want to follow a ketogenic diet would be those who have already or a history of ASCVD or atrial fib, or they have heart failure, kidney disease, or liver disease. We just don't know how the changes, especially with, again, a severely restricted carbohydrate intake, how that might impact these types of diseases. We just don't have any data on that. So really being conservative, trying to prevent or discuss with patients, maybe not trying a ketogenic diet if they have these conditions. And definitely a person who already has elevated LDL-C cholesterol levels, we don't want to have them follow a ketogenic diet. And we'll talk about Dan's patient again here in just a minute. She's a great example. Patients who have severely elevated triglycerides or hypertriglyceride associated pancreatitis, the high fat intake can actually, in those patients, increase their triglyceride levels even more, and that can be increase the risk for pancreatitis. And then, as Dan mentioned, a patient taking SGLT2 inhibitor, because of that increased risk for ketoacidosis, we would have them stop taking the SGLT2 inhibitor before they started the very low carbohydrate ketogenic diet. So the benefits, short term, definitely a very low carbohydrate ketogenic dietary pattern does better than a high carb, low fat dietary pattern, but longer term, for sure, after 1 year, there's typically no difference. And that really has most to do with the adherence challenge that Dan talked about. Generally, we do see a decrease in triglyceride levels and an increase in HDL cholesterol levels. And again, as Dan said, we don't know what the increase in HDL-C levels means clinically anymore at this point. But we do see that consistent in the evidence. Short term, there is a significant improvement in HbA1c compared to with low carb, very low carb dietary patterns compared to those with higher carbohydrate in patients with type 2 diabetes. But beyond 1 year, there was only one meta-analysis that showed that significant difference continued. Consistently, though, patients do tend to need fewer medications for diabetes management and lower doses if they're following a carbohydrate restricted diet. The main thing that we really emphasize, and I always do talk about this when we're talking about the benefits of carbohydrate restricted diets, is that the evidence that's out there, for sure by 1 year, they were not, the patients or participants involved in those studies were not following ketogenic diets. They were not in ketosis. So to me, that lends itself to interpret that people can achieve these benefits on a dietary pattern that is lower in carbohydrate, but they do not need to be in ketosis to achieve those benefits. And I think that's important for us to discuss with our patients. The concerns potentially, as Dan pointed out, there's not a difference between fasting blood glucose levels or insulin levels between the lower carb and higher carb dietary patterns. And patients who do have type 2 diabetes or are on medications, there's that potential for hypoglycemia if adjustments to their diabetes medications are not made as they're decreasing their carbohydrate intake, especially if it's severely, like with trying to achieve ketosis. SGLT2 inhibitors should be stopped, as I mentioned just previously. Patients who are taking vitamin K dependent anticoagulation therapy, similar to diabetes medications, and this could be said for blood pressure medication as well. Blood pressure, that's going to typically be because of their weight loss. As people lose weight, they may need less blood pressure medication. Vitamin K dependent anticoagulation therapy, with those changes to their food choices, especially if they're increasing their intake of foods that are higher in vitamin K, like green leafy vegetables, then it might influence their need for that medication. So paying attention to that. And observational studies do show that both a very low intake and a very high intake of carbohydrate is associated with an increased risk of mortality. So really kind of emphasizing the importance of not just the types of foods that we'll get into here in just a minute, but the amount of carbohydrate, and paying attention to that the extremes on either end may not be the best for our patients. The LDL-C response, we definitely know that some patients do experience an very extreme increase in LDL cholesterol. And Connie, Dr. Soffer's patient, is an example of that. And really that can be impacted by a couple of different factors. Definitely dietary saturated fatty acid, we know increases LDL cholesterol intake even more than, say, dietary cholesterol, but both of those, if a person is consuming a higher amount while they're trying to follow a ketogenic diet, can cause that increase in LDL cholesterol to be extreme, especially if they have genetic factors that result in them being even more sensitive to that, the impact of saturated fat and dietary cholesterol. LDL particle size, more recently, some people are promoting ketogenic diets and saying it's okay, it doesn't matter how much saturated fat they're consuming, a person might be consuming, because the LDL cholesterol that does increase, it's because it's the large LDL particles. And so I just really want to emphasize that we do have evidence that supports that it's really the number of LDL particles and the level or number or concentration of ApoB containing lipoproteins that are associated with the increased ASCVD risk. So it is the number that matters really more than the size. And we know that large LDL particles are associated with ASCVD risk. And so we cannot, safely say that they're benign. And so it also lends information and evidence to support that we really do need to have our patients who choose to follow these types of diets do a baseline and follow up lipoprotein assessments to make sure they're not going to be someone like Connie. And, just really briefly talking through Connie, I just wanted to point out, she's definitely a patient who ended up experiencing quite a severe increase in her LDL cholesterol. And it was most likely, I don't have her dietary assessment, but my guess is she had a very high intake of saturated fat and possibly even dietary cholesterol. Foods that are rich in saturated fat tend to sometimes also be high in dietary cholesterol, not always, but that, and again, in addition to her genetic predisposition, is most likely what resulted in this severe increase in her LDL cholesterol. So what I want to spend the next few slides discussing is how might we address this with our patients who come in. And not all of them are going to be like Connie. So thank goodness, not all of them are going to have this really huge increase in LDL cholesterol, but some might. And so for Connie specifically, what I might start with her because Dan, I know, would for sure refer her to a registered dietitian nutritionist for some one-on-one counseling to facilitate her doing the best she can if she chooses to follow this type of diet continued on, despite her increase in LDL cholesterol. And some patients may do that. So I'd really want to start the conversation with her talking about the benefits versus risks for her. Clearly, she has an increase in LDL cholesterol. So that would be something that we would need to talk through and discuss, is this something she wants to continue? If it is, what are the risks of that increased LDL cholesterol? Right now, she does not have ASCVD, but that is something that we want to definitely talk through with her. But if she's feeling like this is a diet that she's liking, it, maybe she feels better on it, some patients do, then let's talk about what's working for her and start having a conversation about how we might modify some things for her so it's the best of both worlds. She's able to continue following the ketogenic diet if she wants to be that severe in her carbohydrate restriction. But what can we do to maybe assess her ability and willingness to adjust her saturated fat intake? What's she already consuming that we can maybe change and increase her intake of unsaturated fats instead, and while we're decreasing her intake of saturated fats. And there's other things that we might be able to talk with her about to add to her dietary pattern that still fits within the context of her severe carbohydrate restriction and ketogenic diet that may help with decreasing her LDL cholesterol. Again, hopefully in addition to reducing her saturated fat intake. But soluble fiber, we could figure out which fruits and vegetables would fit within her carbohydrate restriction. It's going to be pretty limited if she's trying to keep her carbohydrate intake below 50, but definitely talking with her through some good sources, rich sources of soluble fiber, viscous fiber in the foods that she's able to consume, that she's able to fit into her dietary pattern. We could also discuss phytosterols if that is a possibility for her, but then really being careful to talk about the dietary supplements if she can't find any fortified foods. So it kind of opens another conversation that we'd have to discuss about those types of dietary adjuncts. Physical activity in terms of, she started the ketogenic diet to help with her menopausal symptoms. So really talking with her about the fact that other lifestyle factors can also help with physical activity, with menopausal symptoms, and physical activity can also be helpful for helping address her concerns with keeping her healthy weight as well. And physical activity, obviously, as we all know, is important for cardiovascular health and overall health in general. So we're going to have patients who come into our office who want to give this diet a try, or they're already following this dietary pattern in that they're following a very low carbohydrate or ketogenic diet. So what are my recommendations? We hear all the time that we need to have a shared decision-making discussion with our patients on making medical decisions or medication decisions. We need to do the same thing when we're talking with our patients about lifestyle changes and dietary interventions as well. So really taking the time to have the conversation with our patient and find out where they are, if they feel really good on lower carbohydrate, and even if it's ketogenic, then we need to work with them where they are and have the conversation and be a facilitator and a supporter so that they do it in a healthy way, and paying attention to things that may not go so great. So maybe we see that increase in the LDL cholesterol. So we've created an atmosphere where they can come in, we can identify that and have a conversation so that they are following this dietary pattern, but for that matter, any dietary pattern in the best way for them. And really emphasizing that benefits can be achieved with a carbohydrate restricted dietary pattern. It does not have to be a severe carbohydrate restriction. It does not have to be so low that it becomes ketogenic. And so finding out what might be a best fit for our patient, and then providing education and support. And this is definitely where I'll emphasize using your healthcare team, refer to a registered dietitian for education and support. We are the best healthcare provider in terms of having the background and the ability to sit down with our patients and not only provide education in terms of medical nutrition therapy, of the foods that will be helpful for them to incorporate in any dietary pattern in a way that's going to help them achieve their lipid goals, their glycemic control goals, and their weight goals. And so really we can provide that information about swapping foods out to decrease saturated fat intake if they're consuming too much, replacing carbohydrate foods with unsaturated fatty acids and lean protein, really emphasizing and educating patients on the quality of carbohydrate foods, but really the quality of foods in any dietary pattern, again, as Dan alluded to in his presentation. And then really taking the time as part of that healthcare team to discuss the other lifestyle factors as well. And I'll talk about those in just a few minutes. So in terms of limiting saturated fat, a lot of people may think that if I'm doing ketogenic diet, one, I don't have to worry about saturated fat. And I would say that that is not true. We do still believe saturated fat should be limited. And it is possible to follow a ketogenic diet and achieve less than 10% of the total daily calories coming from saturated fat. Tay et al. Did a great study looking at that and educated patients on how to incorporate more unsaturated fats versus saturated fat. So the first step is really helping patients identify the sources of their foods rich in saturated fats. And so those high fat meats, the fats for cooking that can be higher in saturated fat, like butter, coconut products, lard, and other full fat dairy products that might not necessarily be the healthiest choices, and helping patients then learn to swap those foods out with lean protein foods. So we can get lean cuts of beef or red meat that aren't so high in saturated fat, that can be a really balanced part of a dietary pattern. They may not be as tender, so then that education has to be helping our patients understand how to cook those meats in a way that they are then going to still be flavorful and tender and something that they continue to enjoy. So clearly using plant-based oils instead of those solid fats rich in saturated fat, and then our other foods that are very rich in unsaturated fats that are avocado, lower fat dairy products, nuts, and seeds. And so when we're talking about the quality of foods, it's really looking at this kind of stuff. Ultra processed foods, we definitely know have a potential negative impact on a variety of different things. They may be easier to eat. They may result in us consuming more calories more quickly. So it doesn't have to be fresh fruits and vegetables. Definitely these are prettier pictures, so that's why I put them on here. But you know, a lot of patients may struggle with food insecurity and the cost of food. So helping them understand it doesn't have to be fresh fruits and vegetables, although they can learn how to buy fresh fruits and vegetables in season. But you know, canned fruits and vegetables that are packed appropriately without sodium or without added sugars. Frozen is even better in my opinion, especially if they're not, if they don't have added sugar and salt as well. Whole grains, and when we say whole grains, we're talking whole grains like the bottom picture is salmon and probably bulgur or barley, wild rice, whole grain bread. So it's not just, you know, a lot of people think bread when they think whole grains, but it's really a variety of whole grains, high quality whole grains, legumes, nuts, and seeds obviously can be incorporated and should be of higher quality. And then dairy foods, you know, even if it's full fat, and I know that that triggers a lot of people, but full fat yogurt has been associated with improved cardiovascular outcomes and diabetes. So really talking with patients and again, meeting them where they are and how to fit in foods that they enjoy as part of an overall high quality dietary pattern. The foods we want people to limit, you know, for sure, obviously, if they're on a very low carbohydrate ketogenic diet, but again, any dietary pattern, are the foods that are really highly processed, where, you know, it's parts of our foods, but with a lot of sugar, salt, sodium added into it. Now, I do want to just say one thing respectfully with that table that Dan showed. If we're talking with people who are strong proponents of ketogenic diets, they are going to talk with their patients or their colleagues or their friends about also choosing high quality foods. So I think what happens is our patients are following a ketogenic diet, and what they end up choosing are highly processed foods. And that's, you know, some of the other examples of processed foods. You know, somebody's going to be following a ketogenic diet and they're thinking, well, sausage is great, I'm going to eat lots of sausage on my ketogenic diet. That's not necessarily what someone who is really promoting a very well balanced ketogenic diet would advocate for them either. So I really just wanted to emphasize, I think that's a commonality between the camps, is that all of us want our patients to be choosing healthier and less processed foods. I do want to just really point out in the last few minutes that I have, I am sure a lot of you are aware of Dr. Hall's, Kevin Hall's study that was published in 2019 that looked at 2 weeks of randomized diets, 2 weeks of either on an ultra processed diet and then crossed over to 2 weeks on an unprocessed diet. And what they found at the end of that, and the participants were, 20 stable weight people who were kept inpatient and were able to eat as much as they wanted from either of these diets, 500 calories more per day on the 2-week ultra processed diet versus on the 2 weeks unprocessed. And that was reflected in their weight gain. So 2 weeks on the ultra processed, they gained about 1 kilogram. When they went on the unprocessed, they lost about 1 kilogram. And I just have some pictures to finish out that show you what they were consuming. So these are the ultra processed foods. And as you're looking at these, this is breakfast, think about how many of our patients are consuming these types of foods. And that might be because of preference, but honestly, it might be because this is what they have available to them or have access to or can afford, especially right now with going through the last 18 months that we've all gone through. And so I'm not showing these pictures to say to you, yeah, make sure your patients aren't eating this, but to say, talk to your patients and find out if this is what they're eating, and having a conversation with them about maybe choosing foods that were included on the non-processed or unprocessed diet in the 2 weeks, and figuring out what they can do to adjust what they're consuming to eat less of these ultra processed foods. I mean, I was raised on beef ravioli. I would not eat it now, but these are definitely my preferences now. But again, some patients might struggle with that quick change from eating the foods on my left to eating the foods on my right. So having the conversation with them, figuring out where they are, working with them to make these changes. How many of our patients are eating peanut butter sandwiches with white bread instead of choosing these types of dinners? And then the snacks. Which this is definitely by far more often what we see our patients consuming than fresh fruits and vegetables or nuts and trail mix. So the point of that is that really, if we can start with our patients instead of trying to advocate with some magic macronutrient distribution, just talking with them about where they are and what they're choosing currently, and if they are choosing quite a bit of ultra processed foods, figure out what are their limitations? Is it a food insecurity issue? And then working with them on changing those food choices to making them healthier as much as possible within their individual limitations to choose less processed foods as much as possible. And then looking at the other components of an overall cardioprotective lifestyle, obviously physical activity, sleep, stress management, and decreasing or stopping tobacco. And then again, referring to the healthcare team, all of us are important to provide that support that patients need to make successful lifestyle changes. So the take-home message is really we need to have that shared decision-making conversation with our patients for lifestyle changes, just like we would with any other medical decision. No one macronutrient distribution is superior. So it's very much about figuring out what is going to work best for our patient based on their preferences, as well as their medical needs. And very low carbohydrate and ketogenic diets can definitely improve triglyceride, HDL, cholesterol, and glycemic control. But the evidence that a person has to be in ketosis to achieve those benefits is very weak. And the benefits can definitely be achieved with a lower to moderate carbohydrate intake, paying attention to the effects of LDL cholesterol and particle size, and paying attention to the factors that might be individual for our patients, and helping them decrease their saturated fat and dietary cholesterol intake as needed to make sure that their LDL cholesterol does not stay elevated. Provide that education and facilitation for our patient to be consuming unprocessed cardioprotective foods as much as possible and within their means. Consistent physical activity is definitely key for cardiovascular health as well as health in general. And we need to have that healthcare team to really address all of the factors affecting their success. And that is all I have for you. And thank you for your time. And I believe we have time for questions now.
Thank you very much to both of you for great presentations. We are going to end right at the hour, so we've only got a few minutes for questions. So I won't be able to get to everyone's questions. I apologize for that. One question is, what percentage of individuals can maintain a weight loss of, say, 5 to 10% to a year and 5 years? And I'll direct that first to Dr. Kirkpatrick, and then Dr. Soffer can comment as well.
So I will be honest, I don't know the exact percentages, and I think, one of you may know. I know it's very difficult. 5 years, it's probably zero, in my opinion, maybe close to zero. But I do know that there is the registry, weight control registry, right, Kevin? Where people, so there are people by 5 years out who do have success. I do think that it's important for us to be aware of what those are. The activity is definitely key. Their eating habits are definitely key. But knowing that it's still an individual kind of thing. So we can't look at that registry and think, oh, well, this is what everybody should be doing because that's what these people were doing and they were successful.
I'll just throw in a quick comment. In the pounds lost study, which was one of the larger randomized controlled trials, at 2 years, that's 2 years from the start of the study, there was kind of a 1 year initial period and a 1 year weight loss maintenance period. The average weight loss of 2 years across the groups was about 3 kilos, and that's roughly 3% of body weight. And in studies that we've done out to 2 years, people on average regained 65% of the weight that was lost at the peak weight loss. And Dr. Soffer, any additional comments on that?
I see patients all day long, and I'm always amazed when some people can continue to do one particular thing that I could maybe do for a day or two. And so there are some very motivated, very disciplined people who are able to follow, changes in life better than others. And so individual results vary, but by and large, I think those are fair generalizations.
Thank you. We have a question about LDL cholesterol versus small dense LDL. And maybe Dr. Soffer, you can comment on your thoughts about small dense LDL and where it fits into the clinical picture.
I check the size of LDL particles approximately 0% of the time. I don't find that it ever changes my thought processes and how I manage care. And the NLA reviewed this in 2011, if I remember correctly, and there hasn't been that much literature since then. Smaller LDL particles are more atherogenic. There's no doubt. The environment that enables smaller LDL particles is what causes those particles to be small in the first place. So abdominal obesity, insulin resistance, diabetes, and high triglycerides are all going to promote small LDL particles. Whether or not the lipoprotein profile is atherogenic can be determined with a non-HDL cholesterol level and an ApoB if you need that additional information, but even a non-HDL cholesterol is adequate to answer that question. So I don't find that to be a particularly useful clinical piece.
Great. Dr. Kirkpatrick, any additional comments?
I concur.
Great. There's a question here. I won't ask the full question for time reasons, but I'll just say that the question relates to clinical experience. And it is true that lots of clinicians report that they have good outcomes with their patients on lower carbohydrate diets. Maybe Dr. Kirkpatrick, can you comment on sort of your take-home message about the need to go very low ketogenic versus more moderate carbohydrate restriction?
I guess my take home is that I think there are too many people who would really struggle with such a severe carbohydrate restriction with ketogenic diets. And I don't, as we discussed in our presentations, there's not really evidence that shows a person has to be in ketosis to achieve the benefit of decreasing triglycerides, improving glycemic control, achieving lower body weight. So for me, I believe definitely lower carbohydrate is appropriate for many people. And I'm happy to work with a patient on achieving a lower carbohydrate intake, especially in the presence of hypertriglyceridemia or needing to help with glycemic control. That lower carbohydrate intake at an appropriate level is going to allow a person then to consume foods that we know are associated with improved cardiometabolic health. And that would be the whole fruits and vegetables of higher quality, less processed, the whole grains, the legumes, nuts and seeds, in a more balanced dietary pattern, like the Mediterranean dietary pattern that Dan discussed.
Great. And Dr. Soffer, I'll give you a chance to comment on that, and that will be the final word since we've run out of time.
I don't have any groundbreaking recommendations. I work closely with our dietitian, Fran Burke, and we have conversations all the time with our patients, because I'll see the patient and hand them off to her, and I have a brief conversation. I say, Fran, this is a patient with high triglycerides, insulin resistance, diabetes. You know what to do. And so part of that is it's going to be all of the dietary recommendations that you just gave, with an emphasis on reducing carbohydrates. In our patients who have pure normal triglycerides and HDL cholesterol, no signs of insulin resistance, I don't think she talks that much about that. And that's our goal in treating those patients. We're trying to reduce those patients. We're trying to reduce their saturated fat intake and make sure that they're not eating a lot of processed foods and eating healthy foods, like along the lines of what we've discussed. So I categorize patients in those two ways, and maybe it's overly simplified, but I think the evidence supports that.
And I just want to chime in as we finish up, because Dan and I like to make sure people hear the right message. We're not saying low total fat. So we definitely are not advocates of saying reduce all fat unless it's very, very appropriate, like in patients with familial chylomicronemia syndrome. But looking at saturated fat intake specifically, helping patients reduce that to an appropriate level and replace it with unsaturated fat. So, just making sure people don't walk away from this webinar saying that the MNLA is now promoting low-fat diets again.
All right. Well, thanks to both of you for your presentations and to the audience for your engagement. We will end the webinar now.
Thank you.
Thank you all.
Please email us if you have questions that we didn't get to tonight.